For coming out on this delightful hot summer's evening, as we say in the UK. But the temperature is overwhelming. As Gary said, we haven't seen much of the sun in the sky for the last probably about 6 months. And to step off the plane into Australia and to see that fall in the sky, it was such a delight. But we do get the sun sometimes, but that's why we're both looking at it pale. We're yet to see it yet in the UK. So, just to give you a bit of my background, I'm a podiatrist who's been in practice for about 28 years, and in that time I've worked in mainly diabetes, but predominantly dermatology, and that's been my sort of main professional interest, both clinically and laterally in academia and research. And I've now reached a stage where I'm doing a little bit of clinical, a little bit of research, and a little bit of the educational aspects, but still very much wanting to crack at least one nut before I retire, and one of them being plantar warts. Now, I take it because the room is full tonight, this is something you may see once or twice a year, is that right? Plantar warts, you know, it's a small problem we have. And in the UK, we have a much bigger problem with them, so much so that we have, so much so that we have a place named after this particular water in the north of Scotland. So, is that near you, Gary? You're probably in the mid-central Scotland, aren't you?
I'm central.
Yeah.
Right, and that's the north.
Oh, right, yeah, definitely more warty in the north. But warts are such a stubborn problem, and it's nothing new to say that they're very difficult to get rid of. In fact, if you go back to the literature, and I was looking at some papers published in the 40s and 50s, medical literature about the most contemporary treatments for warts. What was frightening was, of that list of about 12 available treatments for warts in 1950, most of them were still mainstream treatments today, with the exception of, I think it was gunpowder, nitric acid, and radium. It's very hard to get radium. I can't even find it on eBay at the moment. It's very hard to get hold of radium. But so what I'm saying is things haven't moved on much. I've spent many, many years freezing patients and using various treatments, but I think it's really time for change. As I say, if you fear change, leave it here. There's a jar for the FCPodMed as you go out on the door there. Nothing has changed much, and really the outcomes, if you look at the current evidence, are really disappointing. And this has led to this situation where, in the UK, for example, the National Health Service wants nothing to do with warts. It's got budget shortfalls like most healthcare systems in the world, but warts are seen as something that are not very curable anyway, so don't waste any money. So it's fallen into private practice, podiatry services, and such like to really meet that need. And it's a big problem. If we look at the data here, this is from 2018, the very latest data that's published in one of the dermatology journals. We know it's common. We know it's most common in children when they get to secondary school, so teenage years, very, very common. But carry over your infection or acquire your first infection, 18 or 18 plus, then you're much more likely to carry the infection for many, many years. Latest data suggests that around about 7% of adults have plantar warts at any one time, and the lifetime risk is what this paper was looking at, was about 41%, but I would estimate it's probably higher than that. I think most of us probably have a wart at some time on the skin in our lifetime, but it's just catching them and recording them for the data. So, what about the evidence? The main evidence we have, and probably one of the best papers, I think it's one of the most accessed papers in the from the journals, is the guidelines from the British Association of Dermatologists, or the BAD. It's a terrible name for a bad group, but they are the British Association of Dermatologists, who produce every 5 years the updated guidelines. And this was also adopted, the paper was written by James Sterling, but it was adopted by our own National Institute for Health and Clinical Excellence. And this is what it says: if they're not painful, they're not spreading or causing distress, leave them alone, because whatever you do to them is probably going to upset them, and there's a fair chance of not working. So if you need to go to any treatments, it's suggesting the two with the most evidence at this stage are probably salicylic acid and cryotherapy. And if you look through the data, you'll see it's about 62% salicylic acid is successful if it's used for long enough. Cryotherapy, it's about 50% successful, but measuring that is very difficult because there's so many different ways to use cryotherapy. Liquid nitrogen is the only one that they've included in that particular analysis. But what they found is because you probably know with liquid nitrogen, if you're not hurting the patient, you're not doing it well enough. You've got to be aggressive. You've got to go in there and grit your teeth. Go, be aggressive. Yeah, never mind. If you are really aggressive though, you're going to risk scarring and pain. And one of my sort of things that I never really liked much was you do a cryotherapy clinic, you freeze a patient, and then you wonder what's going to walk in next week, don't you? You're lying awake wondering, will that blister come up? Will it be a small blister? Will it be the blister I could get my head into? It's so large. You know, that sort of thing. It gives you that worry because there's no way of quantifying. Now, if you plough through all that data and that particular paper on the guidelines, what's really disappointing, tucked away in a little paragraph near the end somewhere, it says, this is all well and good, 62%, 50%, but when you tease out the data for plantar warts, that data is much more disappointing and suggesting less than 30% successful on plantar warts. So we have a problem, and it even suggests that most adults can expect to have them on average for 5 to 10 years before they're resolved, which is a real issue. And it always made me wonder, well, how on earth do warts stay that long? What is going wrong in the body? What is not happening, or what is happening that means warts are very, very persistent? We have a number of mechanisms, and just to take you back to the good old days of a bit of college knowledge here, but how does the skin work? The skin is part of the immune system, just like every other part of the body. And it can be quite complicated at times, so I've sort of adopted tried to do an analogy here, and I always think of the skin as the local community. So if you just think of a large area of skin on the sole of the foot as being a local community, and what you don't want any trouble on your doorstep, you don't want any trouble in your neighbourhood, do you? So what do we have to control and keep the peace in our communities, unless it's been cut back by our local government?
Police.
You have the police, yeah. In the body, we have our own cells, which are the police cells, and that job falls to the Langerhans cell. The Langerhans cells are one of the many dendritic cells we have in the body. Now, a dendritic cell means it's able to wander. It's able to squeeze through keratinocytes a bit like amoeba, and what it's doing is looking to pick out any cells that have run into trouble. They might have become infected with a virus. There might be something trying to grow into the skin like a dermatophyte infection. But it's the job of the Langerhans cell to be on the guard. It is the policeman. It's parading up and down looking for problems. Now, in your local community, you know, it's Saturday night's party night, and as a party go on late, someone calls the police, and then a bit of trouble happens. What do the police have the powers to do? Hopefully?
Arrest.
Arrest. They make an arrest. So they make an arrest, and how do they do that? They put people in handcuffs and they cart them off. The Langerhans cells do the same. And the Langerhans cells have their own handcuffs. They use receptors on their surface, which is able to latch onto the antigen. But they don't drag them off to the police station. We don't have police stations in the body. What we do have, though, is a lymph node, which is, if you consider that like the courthouse. So they're dragged off to the lymph node, and they're put before the judge for their crime. And the judge in this case is not your right worship of honour of whatever. It is Mr. T-cell. And the Mr. T-cell will sit there in judgment. Now, unlike in the UK, where if a criminal comes to court, we can slap them on the wrist and say, don't be a naughty boy again, have 2 hours community service and pay a £5 fine. That doesn't happen in a node. The sentence is either you live or you die. And that's a bit more stricter actually, and some would subscribe to that, others would probably not, but let's not go there. So the T-cell is then able to impose a death sentence on the antigen if it seems worthy, and as a result the T-cells then become specifically modulated, if you like, to attack that particular antigen. They cloned, they produce large numbers of them, and they all migrate to the site of the infection to destroy the rest of the antigen that's present. It's as easy as that, that's how the system works, very simply put, but that leads to the question, why does HPV persist? Very, very simply, the number of Langerhans cells in the epidermis is quite low compared to other parts of the body. Take your gut, for example. The dendritic cells you have in your gut are much higher numbers than other parts of the body. But in the epidermis, they're low in numbers, so there's police cuts going on. You know what it's like? Can't afford too many police on the beat, so there's less of them. The other thing is the HPV virus is quite clever in the sense that if it infects any cells, generally speaking, it doesn't produce any surface markers on that cell to alert the Langerhans cell. So whereas, you know, in comedy you see criminals dressed up with black and white striped, you know, uniforms with a bag of swag on their, you know, back as they walk away, these are invisible to the Langerhans cell. But in particular, what's coming to light is the HPV has the ability to suppress the immune response by producing a specific protein which can blind the Langerhans cell. And that's part of something called the PI3K pathway. So as long as the wart persists and the virus is in control of those cells, this protein pathway is being triggered, and it remains a bit like Harry Potter. It's like a cloak of invisibility. So it's happy to thrive there, but invisible to the Langerhans cells. So that's where the sort of story goes. It's persistent because it's invisible, it's remote, and Langerhans cells are in low numbers. So how do we treat these things? And this is a student of mine. I'm that old. No. He qualified just before me as a podiatrist, actually, before he did medicine, according to a Facebook page I read. Yeah, I'm not sure either. Facebook is like that. Anyway, he said those who cannot be cured by medicine can be cured by surgery. Those who cannot be cured by surgery can be cured by heat. Those who cannot be cured by heat are considered incurable, and that was Hippocrates. Around about 4:30. That was early. I'm not by now. Anyway, 4:30 BC, I think. So what he was saying is that actually by heating tissue you can get the best out of the immune system, which was completely converse to everything that I was taught. I was brought up, if you like, career-wise in the University of Oxford Dermatology department, and they had the cryo king. One of the consultants was Mr. Cryo himself, you know, the power of the frost being with you always. And anything that moved, he'd freeze. And that was a problem. You had to keep moving all the time because otherwise you just got frozen. But he would use a lot of liquid nitrogen. He taught us all how to use liquid nitrogen, how to strap the patient down, how to keep them under control, and give them 30 seconds at minus 200 degrees. Very popular man at this time. So I always thought, that's interesting. What are we actually doing here? Yes, you're destroying the virus. It's so cold, the virus gets destroyed, and that's why we see such a good cure rate of around about 30%. And then I went to the labs upstairs in the dermatology department, and I was talking to one of the PhD students who was doing research on HPV virus, and they were just getting a sample ready for some test they were doing. And what did? They reached in with a glove into the liquid nitrogen to pull out the HPV virus, which they were preserving the HPV virus in. And I thought to myself, how can you preserve HPV virus if you're freezing it to kill, you know? So it's a bit of a conundrum. So it's very refreshing when this idea of, well, let's do the reverse, because it's long been known that the HPV virus itself is quite sensitive, or much, much more sensitive to heat than it is to the effects of cold. So where does that take us? Well, if we just look at heating the skin, first of all, from the broadest possible sense, there's been a lot of research in the last 20 years which has investigated what happens when you heat the skin. Now, there's different ways to heat the skin. You can heat it gently, or you can burn it to the point of boiling and scalding. But what I'm talking here is heating the tissues to around about 43 to 46 degrees centigrade. This is not killing a cell, it's what I would say giving it a near-death experience. We call this hypothermia, the hypothermic range. So body temperature is around about 37. So you're working somewhere about 7, 8, 9 degrees warmer than that. So, you know, when you run a hot bath, and well, we do in the UK, I know probably more showers with lack of water, but we like hot baths in the UK because we don't get out much. And you always run it a little bit too hot and you stick your finger in it, it's like that. It's sort of, that's sort of hypothermia. Yeah, my other half, I'm sure she's a crustacean, she's like a lobster. She can climb in there at really, really hot temperatures and come out. That was beautiful, and I'm like, I can't go near, it's too hot. Anyway, that's another story. But it's better than stories about gynecology, isn't it? So, hypothermia, this is a whole new sort of science. So there's been a lot of work directed, and something you can have a look on Google, just put in hypothermia effects on various body tissues. It doesn't kill cells, you're not out to destroy cells, but you're just shocking them. As I say, a near-death experience we call heat shock. And when you heat shock cells, there are certain processes that get switched on. What happens is that the primitive mechanisms are then triggered, which cause production of new proteins, which are not normally seen, which kickstart the cell into repair following the damage. Now, if you heat tissues, there's a number of effects that take place, probably 3 main effects, but First of all is heat dissipation. If you can give the HPV virus, a wart is a tumour. It's a solid lump, a random mess of HPV virus cells and maybe small blood vessels. When you heat tumours, they respond much more, if you like, badly to heat than normal tissues because they can't dissipate heat. So when you heat a tumour and you heat normal skin, the tumour will always suffer more damage anyway because it's much more badly disorganised. The second thing is that depending on the amount of heat you use, you can cause tissue damage, as I say, going right up to boiling and scalding and vaporisation. But what the most interesting part about hypothermia is the modulation of a number of immune processes. And that's the key to much of the research that's going on at the moment. Now in about 2004, I think this paper was, yeah, 2002, sorry. This was a state-of-the-art paper which was published on what we knew about hypothermia and the skin and the immune response. And it was a very fascinating paper because it summarised what was known at that time, and that's 16 years ago now, what was known about heating the skin. And if you look at that paper, you'll see this huge table. I wouldn't expect you to read it or probably even be able to see it from back there. But essentially what you have is about 14 different positive effects that hypothermia has on the tissues. Effects on the T cells, effects on the Langerhans cells, effects on the keratinocytes, everything that promotes or upgrades the immune response just by raising the temperature a few degrees. So taking the idea of hypothermia in tissues as being immunomodulatory, move it one step further and say, well, what about hypothermia and treatment of HPV? And this was a study in 2014. And this particular study was looking at, it was very crude, in fact, in many ways, what it did, because it was basically some researchers had got a metal probe that they heated up to about 43 degrees, and they would get patients to come in, and they would place it for about 2 or 3 minutes at a time on each of their warts. And they come in 3 or 4 times a week, and they do that for 6 to 8 weeks, and then review those versus those who hadn't had the treatment. But what they found was, the projector went, oh, it's back. What they found was that the clearance of warts was much, much higher in the group that had their warts heated by this metal conductory sort of probe than those who didn't. So it showed that heating warts certainly had a positive effect. Move it forward a few years, and with the onset and for the first time microwave technology, this is when it starts to get very interesting, because microwave as a form of heating offers a number of advantages, some of which Gary's alluded to already. But very, very simply, just to recap what Gary was talking about, is that it is just simply heating of water in the tissues. Exciting water molecules that are forced to move up and down creates friction, which creates heat. That's all microwave is doing. Microwave's like water. If there's no water there, they simply just go straight through. So a good example would be a nail plate. Microwaves, because there's very little water in a nail plate, you can put the microwave probe on the nail plate. And unlike a laser, if you put laser light into a nail plate, it will be scatter. You'll lose some of the energy. Microwave just simply goes straight through. So it reaches, you know, in the power capabilities it has, it will reach the area that needs to be treated, but simply pass through other areas which are devoid of water. But if you use microwave heating, say, compared to the metal probe they were using in the earlier study, dielectric heating, which is microwave heating, is extremely rapid. It's rather like, you know, if you put a hot spoon on the back of someone's hand, you know, take a few seconds and they'll be like jumping up and down. Dielectric heating is not by conduction, it's by microwave. It heats rapidly in a second or two. So you can heat a portion of skin in seconds. It doesn't rely on conduction, and as I said, it's things like hyperkeratosis and the nail plate are completely invisible, so it will go straight through with no scatter or loss. So immediately you can see on the foot that microwave energy is, you know, useful in terms of plantar surface and around the nails. The device itself is calibrated to a maximum depth of 3.2 millimeters, so you're not going to microwave any of your patients. And for the hundreds of patients I treated, generally most of them will say, well, how deep does this go? And I'll wrap it up and say, all the way, 3.2 millimeters, not far. But they have this view that will sort of go out the top of their foot and then hit the ceiling and rebound and come back again, but nothing like that. The other thing is that microwave, like laser, travels in straight lines. So when you freeze a wart with liquid nitrogen, it spreads like an ice ball, and you get it bigger and bigger and bigger, till eventually it's well beyond the margins of what you want to treat. With microwave, it will only go in a straight line. So here we have a physical modality where you can control the depth, the width, and the energy, and all in all, what that means is potentially you've got a highly controlled, highly repeatable, energy-based method to deposit energy into the skin to have whatever it has, whatever effects it may have. Now, myself and Ivan Jones, who led the lab team at the University of Southampton, were very lucky to be able to get our hands on the very first machine, long before it was released into the podiatry world. This was one of our earliest publications from the British Journal of Dermatology. When we set about this, we knew we were going to have to do a clinical study, but before we even put it on the foot or any part of the patient's body, two things we had to do was A, to make sure that it didn't cause any damage to DNA, i.e. it wasn't causing mutagenesis. We knew it shouldn't, but it was tested by ourselves and we found it was absolutely safe, as one would expect. The second thing was to say, well, what energy doses are we going to need? What do these energy doses actually do to the skin? So what we set about doing was taking some human skin from the operating theatre, very, very fresh, with the patient's consent, of course. We didn't just take it off them while they were asleep. It's not a bit of flesh, but don't worry, it's advancing medical science. But I wanted that. No, you don't do that. It's too late now. So we took some human flesh, epidermis, and we basically microwaved at various levels and dosages to observe the effects, and we compared it alongside cryotherapy. So every spot we did with a microwave, we also did a cryotherapy to a different time to compare. And this is what we found. What we found was very, very interesting, because what we could see at almost at a molecular level was that even at very low levels of microwave energy, we could stimulate cells to go into heat shock. So just a couple of seconds at under 10 watts, we could stimulate cells to release the heat shock proteins. Once the heat shock proteins were there, we could detect those in the laboratory, but what happened next was really interesting, because in that human model, what we saw was increase in Langerhans cells. Not only the Langerhans cells were there, but they were also much more active. So it's rather than the policemen all sitting around having a cup of tea in the, the police house while the crimes are going off, it was booting them out and saying, get out there and work harder. And they were trotting around in the skin, looking very, very busy. They were also migrating, so they're moving. The other thing was that the keratinocytes, as a result of that, were producing more cytokines. So what we're seeing is an upgrade in the general level of inflammation in the area. And there were other anti-tumour responses, for example, like interferon, which was being released. So this got Ivan Jones very excited. He's a dermatologist who's into immunology, and the fact that you could stimulate that with such low levels of microwave sort of held many other questions for him, not just the warts, but for a whole other range of other skin conditions. What was really interesting was, as I alluded to earlier, was the idea that if you use heat, you can actually break the cloak of invisibility. And this may be one of the reasons why microwave was particularly successful in the study, in that using microwave heating unblocked this protein pathway, or blocked it rather, or suppressed it. So there was downregulation in PI3K, which made the verruca more visible to the Langerhans cells and the T cells. So overall, what we had was a very good idea for the first time of what went on in the skin's immune response when we exposed it to microwave. We were also able to allude what dosages are likely to be safe to use in human subjects, what dosage and timings, and that it was very much likely to do exactly what we hoped. What was really interesting for the first time, as far as I could see in the literature, was that we could actually detect no effects of cryotherapy on the immune system for all of the things that we treated. So every bit of cryotherapy we used, none of those effects could be observed in the laboratory. So for all these years we're using cryotherapy, it is probably the effect of the freeze-thaw action, which is physically destroying cells, but we couldn't detect any immune activity as a result of cryotherapy. So what about clinically? We'd established that there was likely to be immune effects. We'd established actually that the device was very safe. There was no mutagenesis as we suspected because it was not an ionising form of radiation, it's non-ionising. So we set about testing the device in a clinical setting. And we took delivery, we had a Swift Mark I device, if you like, as part of the research project. But what we wanted to do as a very first look in the clinic was not to do a full randomised control trial. We needed to know A, if it was safe, and B, if it was likely to be effective in the treatment of warts. Now that we were satisfied at the sort of dosage levels that we had that it was likely to be safe and potentially effective in plans of warts. So, along with myself, team of us, Mike, Chris and Peter, we had 3 centres across the UK which enrolled patients into the study, and this was something we published, and I can give you the full links to the full paper at the end. So this was an open label design. We got ethical approval from the University of Southampton, and we recruited some of the toughest warts we could find. We went out on the streets and we were looking for the real harmers, you know. We asked for the adults. We didn't use children. We didn't want to skew the statistics. We had to have adults who had a persistent plantar wart for over a year, and it didn't take us long to find them. There's plenty of them out there. But to also meet the inclusion criteria, they had to have failed other therapies as well. And we had a few patients lining up. Now, at this stage, we had to exclude certain types of patients. Now, first thing was if they had a pacemaker fitted, because microwave and pacemakers don't go together very well. It's unlikely that, well, it's impossible actually, that if you were microwaving someone's foot with the energy levels, that you're going to cause a disturbance in their pacemaker. But as a general indication, you're told to use with caution in patients with pacemakers, so we just exclude them entirely. As to patients who are pregnant or breastfeeding, I always said to them to put the baby down before we treat them, just in case they drop their child. No, I'm joking. Again, as a general precaution, we excluded anybody who was pregnant or breastfeeding. Anybody with metal implants in their foot and ankle, if you've ever put a fork into a microwave and turned it up to full power and had a little firework display in your kitchen, it's very nice to look at, but when it's your foot that's sparking and arcing away in the clinic, it's probably a little bit more distressing. So if they had any metal implants within the foot, again, we excluded them. And if they were known to be immunosuppressed, now, you know, it's very hard to measure immunosuppression, particularly clinically, but if they had any reason to suspect that they had a reduced capacity to heal or altered immune function, we excluded them from the study. The next thing we had to do was come up with a treatment protocol, and we roughly based it on that of cryotherapy, something that had been advocated through earlier work with cryotherapy. So what we decided was a patient would come in with one or multiple warts, but we would select the largest lesion as the target treatment lesion. We collected the baseline data, and the lesion was debrided to allow the probe to sit on it. It didn't need significant debridement, just enough so that the flathead probe of 7mm could sit onto it comfortably. We then allowed up to 4 treatments using the Swift microwave device, and we paced these at 3 to 4 weeks apart. So patients would come in, they were assessed, baseline data collected, and then the treatment started. Treatment 1, and then 4 weeks later treatment 2, 4 weeks later treatment 3, up to 4 treatments. And at the final visit, they were reassessed and categorised as to where they were. But if they'd resolved in the meantime, of course, we would stop treatment. It will only be marked as resolved if it was no longer visible. The dermatoglyphics had reoccurred, and one of the signs, obviously, of warts regression is when the dermatoglyphics come back in right across the lesion. And it wasn't painful any longer when it was pinched, which is obviously another typical clinical sign that it's a wart and not a corn, for example. If they didn't meet those 3 criteria in totality, they were classified as unresolved. So we recruited a total of 32 patients with 54 warts, roughly equal balance of male and female, average age 44 years old. So we could be confident we weren't treating children or people who were very young. We wanted to give it the hardest job we could. Youngest 22, oldest 71. 54 lesions, you see there 16 single, 38 multiple times. Average size of warts was just over 7mm. The largest wart in the study was 38mm. That's quite a big one. The mean lesion duration, 5.25 years. The youngest wart, if you like, was only a year old. The oldest was 21 years. I remember that lady because she said she'd had her wart as long as she's had her husband. both were proving very difficult to get rid of. I could help her with a Swift with a wart. I'm not sure it had the same effect on her husband. But anyway, the other thing we did was to measure pain scores for patients as a group collectively. So we asked them to rate the day-to-day pain of having a wart on a scale of 1 to 10. And it averaged at about 2.8 with a range of 0 to 7. And by the end of the study, we lost one patient to follow up. He was wandering on the streets of Portsmouth somewhere. We had to go looking for him, but we couldn't find him. And 2 patients had withdrawn, so we lost so three patients with 4 warts. So we immediately classified those as unresolved in the final analysis. The main results that came through, the 54 warts treated, 41 had resolved. That's nearly 76% after up to 4 treatments. 13 or 24% of unresolved. And if you break down the unresolved, 9 of those remained unresolved. We lost the 3 warts and 2 patients who were withdrawn from the study, and the extra 1 patient with 1 wart was still walking around Portsmouth, and we were trying to find him. But never mind, it's a long story. He did return, but after the study was over. Oh, you wanted to see me back? Yes, we did. It's part of the follow-up process. But never mind. The average time to resolution was 79 days, and that's a reflection of the protocol that we actually used. What was interesting and statistically significant was the amount of pain reduction. One of the things that surprised us, and it was a very pleasant surprise, microwave has great ability to reduce pain of painful warts. And as I can say off the record, it's also very good for painful corns as well. It's good at reducing the pain. It's not a cure for warts, but I've got patients with painful corns, for example, I've treated with Swift, and the same effect. That is something in the literature, if you look for other uses medically of microwaves, is a common theme, that microwave has this ability to downgrade and modulate pain. So patients, most of them were very delighted if they had a painful wart to begin with, because literally in 1 treatment, they were finding the pain had gone down significantly. The other thing we had to be very careful was to make sure we weren't injuring, scarring, or causing any damage to patients. So I'm pleased to say that we only lost 1 patient who said it was too painful, but there were no adverse events or scarring reported. We were pretty safe on that basis because we had the data from the lab study that showed that the energy levels we were prescribing for our patients was well below the threshold for causing scarring of any of the tissues in the dermis and so on. So this was a very first study, a first look, open label, and it certainly showed some promise in treating HPV. And I was surprised we got a 76% resolution rate. We looked at the 3 centres, and between the 3 of us, we were all getting somewhere in the 70% range of effectiveness, which was very reassuring that we were all doing similar things, rather than one person having all the successes and the other clinics not. But that was certainly a good point to prove. From a clinical point of view, this is something that got me really excited. It got my colleague, the dermatologist, excited because of all the immunological effects. But for me, as someone who's treated many thousands of warts over the years, this was something that I now had in the clinic, which was extremely rapid, treating in seconds. It's very easy to use, but the main thing for me is the idea is that the device is very predictable and repeatable. You know what energy level you're using, you know what is deposited into the skin because it tells you, and you can predict very nicely what the effect is likely to be on the patient in terms of things. For example, we used a very high dose to begin with in the early days, and we knew that if it went above a certain wattage, you'll get a little bit of hematoma, for example. That doesn't happen so much because we've found we can downgrade the modality we used. No anaesthesia was required. No patient in that study has had anaesthetic, and no patient treated in any of those 3 clinics has ever had an anaesthetic. And that's good because it means that it speeds up the procedure. No smoke, and unless the lesion bleeds, of course, when you debride it, which warts occasionally do, there's no need for post-operative dressing because it doesn't break the skin. It merely heats it. And when you've concluded the treatment, you just put your finger on it after you've done it, you'll feel that it's warmer than the surrounding tissue, and you know the job is done. And the patient can then leave, they can bathe, they can shower, they can do whatever they like. And I think that's what patients also like, is that they can come in once a month for a quick treatment, and then they can leave and they don't have to worry about keeping a pad on it, or using an acid, or staying out in water, keeping their foot dry. So this is a sort of moving forward then, and as a result of the work, we've got 4 publications to date. First one was British Journal of Dermatology, and then there's 3 others. These are all available and open access. They're available through my website, my own personal blog site, along with lots of other things, but they're also available from the journals involved as open access papers. What about the clinical side of things? The proof of the pudding is always in the clinical side, and I'm really pleased to say that I could have showed you about, over 100 from my practice which have resolved, but I'm not going to, fortunately. I'm just going to show you a few of the successes that I've had. And as I said, consistently, I'm auditing my results and success levels near or more or less on what we found in the clinical studies, which is very, very reassuring. I think the key thing to say about this modality is that it's one, and it's not the only modality. So when a patient comes in who's looking for a treatment for their warts, it's important to explain what this treatment is about. And consent laws in the UK, I'm sure they're not far different from those in Australia, means that the patient, before they can give consent for microwave treatment, needs to be informed about what it is and also what other alternatives are. So they need information, and I never treat on the first date. Okay, if a patient comes in for an assessment, I will never say, right, let's do a bit of Swift now, if you fancy it. I will always send them away with information on all the treatments that we offer, but more often than not, they've read the literature and they're all rebooked for Swift. That way I know that they're fully consented. And that way, I can also temper the patient's expectations. You can say to them, well, these are the success rates, 76%, whatever, and it gives them time to think it through, and I think that's very, very important. And it's also important to give them the right advice. We inform them, or I want to say in the clinics that we work with, the 3 of us, we inform them research results, and the average treatment for most patients is 3 to 4, and then we leave them for up to 12 weeks. Because one of the things about the immune system is you're not destroying this wart, you're kicking the immune system. And one thing we've learned in the study and the follow-up data from the study was that the immune system can take up to 12 weeks after the last treatment to actually kick in. And also in small groups of patients, they may need more than 3 or 4, particularly in the older patient. And when I say the older patient, we've got patients we see regularly in their 70s and 80s. I even had a 92-year-old came in seeking treatment for warts. But subsequent, what we know is that patients in that sort of octogenarian age group and beyond will take a longer time simply because your immune system is slower to respond. Also, older warts and larger warts, as you'd expect, take longer to shift. They do go, but you have to tell the patient, it's going to take longer. And patients who may be on polypharmacy, so they're on lots of different drugs, some of those also can affect and interact with the effect. But also, a lot of lesions resolve in less than 3 treatments. So it's a balance, and it's sometimes hard to predict, but that's just my sort of clinical experience as to what's needed. But for most patients, they'll have a good outcome. Now, the key thing here is what dosage you use. That's always the question. Well, this is again consensus from our data colluded with the post-marketing survey carried out by the company. But in most cases, what I'm tending to use in day-to-day practice, for each area treated using 8 to 10 watts as a 2-second dose. So if I have a 1 wart under the metatarsal head here, and it's the size of the probe, for argument's sake, I'll set it to 8 to 10 watts for 2 seconds. 1, 2. And I'll do that up to 5 times. The more, the better, 3, 4, 5. And you do that, and if it's a larger lesion, you keep doing that till you've more or less covered the whole lesion. You don't need to be exact, but you need to get the bulk of the lesion. So by the time you finish doing 5 treatments on that 1 wart, you put your finger on it, you can feel it's warm. And the patient will get a little bit of pain, usually by the second, it's like being jabbed very, very quickly with a needle. They'll jump or they'll say, ooh, felt a bit hot. But as soon as the machine stops, then the pain goes away. So as long as the microwave active is a bit uncomfortable at the very end of treatment. But as soon as the machine stops, they put the shoe on top of and they walk out and they say, can you feel anything? Most of them say no, or it just feels as though it's a little bit warm. And what we try to do is see them every 4 weeks. That seems to be the optimum time. We have tried cutting the time to see if we can get rid of them faster. But again, you're fighting the immune system. The immune system has its own circadian rhythm, if you like, and 4 weeks seems to be the optimum. But at each treatment, to each area we treat, we aim to sort of deliver 80 to 100 joules. So that's basically seconds times by watts, gives you your joules. So it's very easy to calculate what you can deliver. So let's have 4 cases. We've got a female patient who's, this is one of more laterally treated patients, 56 years old. She's had multiple verrucular heels for 2 years. Generally fit and healthy, didn't really bother her much, pain level 1, but they were annoying because she's had them a long time. She's been seeing a podiatrist who'd been putting salicylic acid on it for a year and charging her £35, or so about $70 each visit for a year. Worked that out over 40 weeks. She spent a lot of money on these warts, but nothing was shifting. So for this lady, she wanted them all treated, so she had 8 watts, 2 seconds, 5 applications per site at each visit, and then we saw her back 4 weeks later to assess progress. First thing usually happens is the patient said, oh, I can't feel it anymore. You know, there's no pain from the warts. They may go a little bit darker. You can see some changes. But with this lady, by the time she'd had the second treatment, she was due the third, it was very clear they were going into regression. So she only ended up having 2. And she was left after 2 treatments, and then with the 12-week follow-up we always do, this was the outcome for that patient. But very, very happy because she only needed 2 treatments. Next patient, another female, 18 years old, multiple lesions, 6 years duration, but these were very, very painful, level 6. And she was someone who was keen to go dancing, and this was really stifling her dancing career, these big, thick, horrible warts that she had on the soles of her foot. And just again, the same routine, 8 watts, 2 seconds, 5 applications per site, 4 weeks apart. She also had one, just to show you, one on her toe there. And again, after 2 treatments, they were moving very nicely. She said the pain reduction had been significant, but the warts actually looked as though they were resolving. You get this sort of, they don't necessarily involute. What happens with microwave is they get thinner and thinner and thinner until they just disappear. But that was after 2 treatments, 14 weeks in total. And the one on her toe was gone as well. And it's not unusual for patients to see other warts on their hands disappear at the same time. I see that on probably 50% of cases, patients sort of say, well, actually the other warts have gone now. But many patients, if they're having SWIFT, will say, treat them all, please. We'll treat as many as you can. I want my money's worth from this. And they're very pleased to do that. This next patient is a patient that I saw, he was one of the first that I saw in the study, and he was a gentleman, he was about 32 years old, and he came to me because he'd had this wart for 5 years, and the wart itself was not painful, only when he wanted to play football. And he left playing 5-a-side football, but the throbbing and the pain from this beast was such that he couldn't play football anymore. So he'd read about the SWIFT treatment in an article I did in the Daily Mail, and he'd come along for me to give it a treatment. And that's exactly what I did. And I used, for this patient, 10 watts, 2 seconds in a similar manner. Now, that's what it looked like when he turned up after the first treatment. You can see the sort of 4 corners that I've treated there. Not much to show, but what he told me was interesting because he said, I've been able to play football now for the first time in years. Thank you very much. I don't care if this doesn't get rid of my wart, just, you know, as long as the pain stays away, I'm really happy. But I wasn't going to let him get away with it that easily, so I gave him another 80 joules into the wart, and this is what it looked like at the 3rd session. By that time I knew, because I could see the dermatoglyphics coming in, and the scab there, the lesion was on its way out, and indeed there was no pain. This is how it was at 6 months, and you can see just vaguely where that wart was in this patient. Final patient, a male, 69 years old. He had this beast for 5 years, and it was really painful. And he was on quite a few drugs prescribed by his GP, so I knew it was going to be a little bit of an uphill battle. But it was thick, it was painful, and it was horrible. And he said when he was trying to walk to the shops and do normal everyday things, it was like a throbbing beast on the sole of his foot, just gnawing away at his bunion. And that's his words, not mine. Very, very graphic. Some patients aren't they, what they tell you. Anyway, so this is what we did. We did a treatment using 10 watts, and in this case we used 2 seconds. Now, when they're really, really thick warts, you can really put the power up and even do 3 or 4 seconds with thick warts, and patients hardly feel it at all. And they massively debulk within the first 2 treatments, and then you can get down further into the lesion itself. But this was after the first treatment. As you can see, bits of it fallen out. and he'd noticed a slight reduction in pain, so he was fairly happy. He said, well, it's only a week gone by, that's good. Now, by week 16, he'd had 3 or 4 treatments, which is sort of normally the end point, and we'd leave him, but he said, no, please carry on. Now I'm pain-free, it's still there, but there's hope. So he was happy to go on. And by week 20, not much happening. Week 24, suddenly, these dots were appearing, and he said the pain has drastically gone. By week 36, I left him at that point, week 36, the lesion had gone, he was delighted. But it just goes to show you sometimes these things take time, but the fact that he was responding and his pain was reducing, and he felt it was better, he could feel the change, gave him the impetus to carry on with the treatment, and he was delighted because he tried every other treatment in the book, including needling, cryo, and all sorts of modalities. But the other thing that sort of struck me when I introduced the practice was how good it is on hand warts. And we've got patients now coming in with warts on their hands, and I'm very happy to treat them, particularly if they've been referred by the GP or a consultant. In the UK, we can do that quite legally. And we've now got lots of patients coming with hand warts, and it's equally effective. And to be honest, children, not that we treat large amounts of children in our clinic, respond really well to Swift. And I can touch wood here and say that of all the children I treated, probably less than 10 in total, because they're advised they will go away, but some children are old enough to give consent and wish to have them treated. They have all disappeared with Swift treatment, which is something I've never had before. So very, very delighted with that. Otherwise, oh, yeah, there we are. That's all I was going to say. I'm happy to take questions. I'll hand back to Mark. But just to say, if you want to know anything else anymore, my website, foot.expert, has got lots of podiatric dermatology on it, including bits and pieces from Swift and other things. So please feel free to subscribe to the website for any information. It's all free. And I will hand you back to Mark.